So Dr. Green, we'll start with you. Out of all the areas in orthopedic surgery, what was it about the shoulder that interested you?
So that was back in the late 80s, early 90s, and that was when shoulder surgery was just beginning to become a subspecialty in orthopedic surgery. And when I trained here at Rhode Island Hospital and Brown University, we really didn't have a shoulder surgeon, and we did very little shoulder surgery. But the shoulder always intrigued me as a very complex part of the body. There's a really interesting anatomy, and then the conditions and injuries that we treat encompass all ages. So it was that got me interested in shoulder. I had some experience with patients as a resident, and then decided I would pursue this area of interest. And I think my decision was a great decision because it has allowed me to take care of lots of different types of patients and different types of conditions. And most specialties don't really afford you that opportunity to take care of young patients who are athletic, middle-aged patients who are active, older patients who have degenerative conditions, and then at the same time use different techniques in surgery, such as arthroscopic surgery, which is less minimally invasive, open procedures, joint replacement procedures. Most other areas don't encompass all of those, so it's very interesting for us to do. And then the other aspect was the ability to teach people about shoulder conditions and shoulder surgery, which I got to do by joining this practice.
Dr. Paxton, the same question to you. What was it about this specialty that got you interested and inspired?
So a lot of the same reasons that Dr. Green mentioned. Where I trained, there was a very strong shoulder and elbow division in St. Louis at Washington University. And so as a medical student, I began doing some research with that division, and it really intrigued me. Throughout residency, I wanted to kind of keep my options open, and so I did research in a number of areas, and I kept gravitating back to shoulder surgery for a lot of the same reasons that Dr. Green did. Do open surgeries, we do arthroscopic surgeries, we do joint replacements, we fix fractures. We really do everything for the shoulder and the elbow. We don't really need to refer patients off, which I really liked. I really liked the idea of being an expert in one area and being able to do all facets of surgery on that one area, not knowing, most of things about a lot of areas. I want to know everything about one area. And then did fellowship training after that in shoulder and elbow surgery for a year, and then have been here ever since. And again, allowed me to teach, and also we do research as part of our academic mission. And shoulder surgery it's a bit young, as they kind of say, with shoulder replacements really gaining popularity, and the first ones going in the 1970s, but in the 80s, 90s, things like that. So it was still early, and we still have a lot of opportunities to improve things, and there's novel innovation coming out. So a lot of opportunity to help people in the clinic, but also to do research and things like that at the forefront to improve the specialty.
Great. And I'm sure a lot of folks who maybe haven't had a shoulder injury may be surprised to hear that it's so common. And I think the logical question that follows is, what are the most common shoulder surgeries that you do? And Dr. Green, I'll ask you that question. What do you see the most of, and what do you do the most of?
So the thing that we see the most is conditions related to the rotator cuff. And that can be from an injury or from just wear and tear and aging, overuse. So because of that, rotator cuff repair is the most common surgery that we perform. And thank you for bringing these slides up. So on these slides and images, some of which I took from the American Academy of Orthopedic Surgery website and from my own cases, this is a demonstration of a rotator cuff tear. We can see the rotator cuff tendons and muscles, and they're critically important for the function of the shoulder to control the ball and socket. The ball and socket are much like a golf ball and a golf tee, as opposed to a hip, which is a real contained socket. So you have to have a good rotator cuff to surround that and keep it in place. Rotator cuff conditions are very common. They become more common as we get older. And this is a typical example of a rotator cuff tear. We can see on the diagram, the cartoon, from two different views. And then on the right-hand side is an arthroscopic picture of a large rotator cuff tear. And typically what we'll do in a patient who either has had an acute injury with a tear, where we might opt for early surgery, or someone who's had more chronic symptoms and has failed non-operative treatment. And I want to emphasize that a lot of rotator cuff conditions and tears can be treated without surgery. We'll do surgery, and if you, I think if you go to the next images, we have some pictures of surgery. And the idea is to reattach the tendon to the bone so that the muscle can act across the joint. And on the left-hand side, that's an image from an arthroscopic surgery where you can see the opening between the tendon and the joint. And then on the left-hand side, there's sutures that are coming out of a suture anchor. And when we do these repairs, we put anchors into the bone, and then sutures go into the tendons. And then those sutures are tied or pass through the tendons and anchored again so that we can move from the left picture to the middle picture and see the repair. And then on the right-hand side is actually a picture of an MRI of someone who's had a repair, and we can see the tendon at the top part of the rotator cuff is reattached. But the goal is to restore the tendon and bone interface so that the muscles can function. Tears have a variety of sizes. There are small tears, there are tears that are massive, and the techniques are similar, but one of the nice things about rotator cuff surgery, even though it's so common, is that every case is a little bit different. So it gives us some variety in terms of who we treat and how we treat them. But by far the most common problem that we treat relates to rotator cuff problems, and the most common surgery is rotator cuff repair. There are a number of other conditions that we have some images for as well to highlight some of the other common shoulder problems. And hopefully this will stimulate some questions from the audience.
So this is another entity that we see and treat. This is an x-ray of somebody's right shoulder, and they have a shoulder dislocation. So we can see the ball, which looked like the ball in the socket, which is relatively flat, and it's superimposed over the ball. And so this shoulder is dislocated because the ball is out of the socket, and it's come out anterior, which means in the front, towards the chest, towards the front of the body. That's the most common way that shoulders dislocate. And so this generally would be put back in place either by the patient at the time that they dislocate, potentially if they're on an athletic field or something, by a trainer, or in an emergency department, or occasionally in the operating room. But this is something that we treat commonly after the shoulder has dislocated, has been put back in place. There often are problems that come about as a result of the ball coming out of the socket. And those can differ depending on how old the patient is. So there's what's called a bimodal distribution, meaning there's two peaks in when we see people dislocate. We see our young athletes, 18, 19, 20, playing sports, contact sports or collision sports, as sometimes they're referred to. And then we see another peak as patients get older, around 65, 70 years old. A lot of times the people who do have one of those degenerative rotator cuff tears like Dr. Green spoke about that comes along with aging. But when older patients dislocate their shoulder, they can do a lot of different things: stretch nerves, break bones, tear the rotator cuff. Generally, when a younger patient dislocates the shoulder, they'll do what we see on the next slide here, which is tear something called the labrum. So we see an arrow pointed to that. It's like a bumper that goes around the outside of the glenoid, which is the fancy name for the socket. And you can see that the glenoid's relatively flat, and we need this bumper. But we also, more than as a bumper, there's ligaments that are connected. So Dr. Green mentioned before tendons. So what tendons do is they attach muscles to bone. So it goes muscle, tendon, bone. What ligaments do is they attach bone to bone, and they help with stability. So there's ligaments around the knee, there's ligaments around the shoulder, and the ligaments attach to this labrum. And when the labrum's torn, it can lead to the shoulder re-dislocating or coming out over and over and over again, which we want to try and avoid. And so the surgery that was done, and we see the picture on the right, shows the labrum is now repaired back with suture anchors and suture, like Dr. Green showed with the rotator cuff. These anchors are a little bit smaller, and this is a newer technology that we have where we do it without tying any knots. It's called a knotless repair, which can avoid some of the problems with tying knots, but it reestablishes those restraints to stabilize the shoulder. And sometimes when people injure their shoulder, they don't just injure the soft tissues like this, but they can even fracture the shoulder. And so we can go to the next slide.
So proximal humerus fractures are the most common fracture around the shoulder. and we see a lot of them. These are generally the same type of distribution where we'll see younger patients who have very traumatic injuries that result in a fracture, and then older population or older patients who have bone that's not quite as strong and will have fractures from injuries such as a simple fall, something that's not that traumatic. A lot of fractures can be treated without surgery if they're not displaced and heal and do well with rehabilitation. This is an example of a more complicated fracture where the ball or humeral head is knocked out of position and the bone around it, which is all attached to that important rotator cuff, is displaced. So in a case like this, we would want to fix the fracture to restore the anatomy, and that's what's been done here with a metal plate and screws. And over the last, I'd say 10 to 15 years, there's been a lot of innovation in terms of the type of implants that we might use and the techniques we use to fix these fractures. Certainly a lot different than when I was a resident with Pete Lucas's father, actually, and we would fix fractures. These are relatively common injuries. The more complicated fractures are not as common, but if we can restore the anatomy, we can help restore the function to a patient and enable them to return to their regular activities. There are fractures that we do that are bad enough, in some patients who are older, that we actually replace the shoulder instead of fixing the fracture. And I think we actually can move on to the next slides where we have a shoulder replacement. I'll let Dr. Paxton talk about anatomic total shoulder replacement.
So it's interesting in the shoulder, we tend to see more soft tissue injuries. And when we see soft tissue, I mean tendon or ligament. So we have those rotator cuff issues, those rotator cuff injuries. We still see arthritis in the shoulder, but it's not as common as the soft tissue injuries, which is a bit different than some of the other joints like the hip or the knee, which are weight-bearing joints, which generally arthritis is what most patients are presenting with as they get older. But we do see patients with arthritis of the shoulder, meaning that the cartilage, which is white, shiny, soft tissue that's between the bone and the socket and allows them to slide around nice and smooth, is destroyed. And it's generally wear and tear or osteoarthritis. So the x-ray that we see on the left shows an x-ray of somebody with osteoarthritis where there's some bone spurs, also referred to as osteophytes. And there's no space between the ball and the socket. They're bone-on-bone arthritis. And so we go in, it's called a replacement, but a better term, probably a resurfacing to some degree. But we remove the portion of the head and we put a metal implant. And we see that on the x-ray on the right. That's a nice smooth sphere. And then we put a plastic piece made out of polyethylene is a technical term on the socket, or the glenoid side. And so then it's metal on plastic as opposed to bone on bone. And one of the new innovations over the last 5 years or so is something called a stemless component. And we see that here where there's not a big stem going down the center of the bone. So if you see an x-ray of a hip or an older shoulder, there's a big stem that goes right down the middle of the bone. This is a much smaller stemless, or canal sparing is also the other term for it. And one of the benefits is that if it needs to be redone in the future, there's a lot less bone destruction that potentially could happen, and we can save a lot more bone to do a more straightforward and predictable revision surgery if that should need to happen, especially if we're putting a shoulder replacement in a patient that's younger, where the possibility of needing to have it redone in 20, 25, 30 years is there. So this is probably half of the shoulder replacements we do are this type of an anatomic shoulder replacement. So we replace the ball with the ball, socket with the socket. The x-rays look pretty similar. It's just there's metal and plastic there. And there's other conditions that I'll let Dr. Green discuss where we use a relatively novel type of shoulder replacement called a reverse shoulder replacement.
The anatomic replacement that Dr. Paxton was talking about was developed in the 1970s and then became more popular in the 80s. And the goal was to restore function in someone who had an arthritic shoulder, but it really depended on having a good rotator cuff, which we had mentioned earlier. What's interesting about osteoarthritis is most patients with osteoarthritis have a good rotator cuff. And on the flip side, most patients with rotator cuff tears do not have arthritis. But what's happened over the past 20 to 30 years, particularly with the baby boom generation, is that there's a larger population of patients who are getting older who have rotator cuff tears that are getting worse, and they develop what's called rotator cuff tear arthropathy. And they have arthritis and a rotator cuff tear. And the anatomic replacement just doesn't work well because the joint is unstable without the rotator cuff. In the 1990s, a gentleman in France took an old concept that had been around in the 70s that didn't work well, but with newer technology, they were able to develop what's called the reverse total shoulder replacement, where we put a ball where the socket is and a socket where the ball is. And this is a patient who's had previous rotator cuff surgery years earlier, who eventually went on to have progressive rotator cuff tearing that wasn't repairable and arthritis, and then we're able to treat this with this reverse total shoulder replacement. And I was involved in the development of one of the replacements a number of years ago, and there's been a lot of innovation in this area to improve the longevity of these implants. And what's happened is, where we originally were doing these replacements for older patients because we were concerned about how long they would last, we're now doing them on younger patients for a variety of reasons. And at this point, about half of all shoulder replacements are now reverse replacements, and half are anatomic, whereas it used to be all anatomic. So this is an example of the type of innovation that's happened in shoulder surgery to improve the quality of life of our patients. I think the other thing that we should point out here is what about after surgery? And all of these surgeries are that require postoperative rehabilitation, and the rehabilitation is very, very important in the recovery for these patients. And I'd like to put a thank you out to all the therapists who help us in our practice and outside of our practice to manage these patients after we've done their surgery. Shoulder surgery, I think, has a reputation of being difficult to recover from. I think that is variable, but we couldn't do it without the postoperative rehabilitation.
And I'm looking over and I see Dave Pizzullo, Director of Physical Therapy, joining in. So he is one of those folks who heads up a big crew that you're speaking about. And interesting to note that you have physical therapists located all over the state, so very convenient for that rehab. But I thought that was a fantastic presentation. I think the images are great for folks at home to see just what goes on the inside. You feel a pain and talk about it, but until you actually get to see some of the hardware and some of the images, that paints a really great picture. So we encourage anyone to submit their questions, and we will do our best to answer. And I think one that had come in earlier, when do you know if you need to have surgery? Dr. Paxton, I'll start with you. It's a pretty common question. People have pain. What's the point where you need to have surgery?
Yeah, so that is, that's really the reason that we do all the training that we did, why we continue with continuing medical education, why we read journal articles, why we do research, why we go to big conferences, is because that's not always as easy as a question as it may be, and it's different for every patient. So I can't give you a blanket answer. When this happens, you need surgery. When this happens, you don't. That is one of the unique and fun things about our job, is that we get to interact with individuals on a daily basis, a lot of them. And you really have to individualize your care to the patient based on their x-ray findings, based on their physical exam findings, based on what they want to do, what their job may be, what their activities, what their hobbies are. And so a lot of the decision comes down to the patient making the decision. So I think Dr. Green and I have the same philosophy, that we really want to do something that in medicine we call shared decision making, where we provide as much information as we can to the patient to let them know what the pluses and minuses are of each, possible outcomes with surgery, without surgery, what may happen in the future, to allow them to make the decision. Because ultimately it's their shoulder, and they're the one that's going to need to go through the rehab that Dr. Green discussed. But, to give you a little more detail and not totally back out of the question, a lot of it depends on whether it's an acute injury, meaning there was an injury, a trauma, somebody fell down the stairs, a car accident, they had some sort of an acute accident to the shoulder, or whether it's a degenerative problem, whether they're coming in saying, doctor, my shoulder's hurt for a year and I don't know why. I don't remember hurting, I don't remember what I did, and that's more of a degenerative problem. So the timing can be a bit different with both of those. With an acute injury, if there's an acute tendon rupture or a fracture, things like that, obviously the surgical intervention may need to be done sooner or at an earlier time point to restore whatever was torn or broken. If it's a more degenerative wear and tear type of issue, then we generally like to present all the options, but with the vast majority of those, you can start with conservative treatment, back to our therapists who are our good friends to help out. As we saw earlier, the surrounding muscles, rotator cuff muscles, are all very important in how the shoulder works. And so sometimes it's as simple as retraining those, strengthening them, and you may be able to avoid a surgery. Corticosteroid injections can also be beneficial, especially in the patients with arthritis. But ultimately, they may not respond to those. And then it really is, how much is this impacting you? What are the possible future risks of not having it fixed? Is it something that can get worse over time? And that's where we really take that detailed, patient-centered approach.
Dr. Green, I'd like to hear your thoughts on that too. It's such a big, broad question. I'd like to hear your input.
A lot of it depends on what the condition is, what the individual patient is looking for. What are their goals and expectations? What typically drives most patients to have surgery is either they've had an acute injury with an injury with something that probably isn't going to heal by itself, and if it's left untreated will lead to some type of functional deficit and pain, or they have pain related to their arthritis, their rotator cuff tear, that hasn't responded to appropriate treatment. And I think it's very important for a patient to be well educated in what the condition is, what the options are, what the implications of doing treatment is. We talk a lot about rotator cuff tear. Should you have surgery or shouldn't you have surgery? There are studies to show that either treatment is going to be successful, but what does that really mean for someone who's 40 years old or 50, 60? Does it matter if you leave a tear unrepaired that won't heal by itself? You have to understand what the natural history is. So we get a good history from a patient. We examine them thoroughly, get imaging studies such as x-rays and MRI to evaluate the condition, and then help them make a decision based on our understanding of the evidence. What have people studied? What do we know about patients? What's the natural history of the condition? I would say probably the most important factor for most patients who have not had an injury and had more of a atraumatic onset of pain is their pain. That they have pain that limits their function, makes it difficult for them to sleep, and they get to the point where their quality of life is being affected enough that they're interested in having surgery to treat the problem, go through the recovery and rehabilitation, and then come out much better at the other side. And it's our role to guide them in that decision making, but not necessarily to make the decision, and then to help them with the decision. And I tell patients, I'll help you regardless of what decision you make. And because my goal is to make you better and to get you as good as you want to be, and with that, to be successful at that.
Dr. Paxton, we had a question come in. What is a typical rehab time for shoulder surgery? And maybe when answering that question, what does that involve?
So the typical time on average for most shoulder surgeries that involve a repair. So sometimes we'll go in and do a surgery that may just be a cleanup or a debridement of a certain area. Those a lot of times can rehab a little bit faster. But generally anything that requires a repair, a rotator cuff repair, a labral repair, things like that, on average about 6 months. But in general, patients will continue getting improvement up to a year. It doesn't mean it's going to take a year to get back to all your activities, but most patients, if you see them at a year and say, hey, how do you feel now compared to 6 months ago? They'll say, I feel a little bit better. So they still get a little bit of improvement. The bulk of the improvement happens probably within the first 3 to 4 months, but we usually say about 6 months before patients are back kind of to full activity. But they will get a little bit of improvement up to a year. Typically after surgery, though, there is going to be a period, and I think this is what most patients are interested in, is how long they're going to be in a sling. How long are they going to be without the use of that arm? And generally with a repair, it's going to be somewhere in the range of 4 to 6 weeks, where we want to keep them in the sling so that, when we put those tissues back together, it's nice and still so they can start healing together. So whether it's the tendon or the labrum or whatever it may be, can heal back together. If there's a lot of motion and movement, it can disrupt that healing.
And Dr. Green, on top of that, what should expectations be? Do patients ask you, will I ever get that motion back? Will I ever feel right again? What's the answer to that?
So for most of what we do, patients should get close to normal motion. There are some limitations in terms of certain types of replacements and what we can expect in terms of their return of mobility. But by and large, a rotator cuff repair patient should get their motion back, should have great pain relief. And then their strength is going to depend on the size of the tear and the amount of muscle degeneration that occurred before they had their surgery. But the vast majority of rotator cuff patients are going to have pain relief and great function, and that should be very durable over their lifetime. Instability patients should restore stability, be able to get back to their functional activities, whether it's a sport or collision sport or a recreational sport with a low recurrence rate. Fracture patients, a little bit more variety in terms of how well they do, but if we restore the anatomy and we have a very motivated patient, I think their recovery tends to be harder. They should get most of their motion back and have a very comfortable shoulder that's very functional. An anatomic shoulder replacement, in most patients will get great motion, great pain relief, and that's very predictable. That's probably, that and reverse shoulder replacement are probably the most satisfying procedures we do, because although the recovery takes about 6 months to 12 months to get to final result, most of those patients have pain relief within a few weeks of their surgery, and their recovery is a lot easier than some of the other surgeries like a rotator cuff repair. And that's actually one of probably the most common misconception, is that a joint replacement, which seems like a really big operation, which it is big compared to a little arthroscopic rotator cuff repair, has a much easier recovery and the patients are comfortable much faster. And as Dr. Paxton said, most patients with all of these surgeries, after 12 weeks or so, they're not fully recovered, but they're back to their daily activities. They should be very comfortable and see the light at the end of the tunnel, so to speak.
And Dr. Green, you touched on the technology improvement a bit there and how things have come a long way since you started. We saw some of the pictures. Dr. Paxton, talk about that, the advancement in technology and some of those replacements, how that recovery time has sped up, and how maybe people thought about a surgery like this, putting them out or in the hospital for a week, now can be in and out in a day.
Yeah, I think it's multifaceted, the advances that we've made. There's been advancements in the overall technology, the materials that we use, how they're shaped. We saw the picture of the canal sparing type of replacement. That's one of the areas. Other areas are advancements in just technique, how we do the surgery ourselves. As we do more, there is obviously more opportunity to learn, and there's opportunity for people to become specialized in this. And there's a relatively good amount of data to show that higher volume surgeons, meaning people who do more of this specific type of work, such as shoulder replacements, generally do get a bit better results, which makes sense. If you're doing 100 of these a year, it makes a bit of sense that you may get a better result than someone who only does 1 or 2, which was one of the benefits at University of Orthopedics, that we do have subspecialized surgeons, that Dr. Green and myself, just work in this area. And so we do a lot of these procedures, and so we're very familiar with them. And then we've had advancements in the postoperative recovery, whether that's how long patients stay in the hospital, where maybe initially they were planning to be in the hospital for 5 or 6 days, and now the vast majority of our patients leave the morning following surgery, and there'll probably be a move here to some outpatient or same-day surgery in the future, which is happening in hip and knee surgeries. So all those have come together and created benefits for patients overall, and they've made us more comfortable putting these types of replacements, as we're sticking with the replacements, maybe in some younger patients now, whereas when it first came out, like the reverse, it was generally patients above the age of 70 who would get one of these replacements. And now we're doing them in younger patients because we're confident in the technology and in the implants that we have.
And Dr. Green, I'd love to hear your answer on that as well. You've seen a big shift in technology and improvement through the years. What strikes you the most, and what's the most exciting for you?
So I'm, I guess, a little older than Dr. Paxton. I don't consider myself too old, but I was able to come up through shoulder surgery from the all open to the arthroscopic and much more technically advanced shoulder replacements. And so I've seen the innovation. I've been involved in a number of design developments for shoulder replacement, done some work with arthroscopic techniques as well. I think on top of that, what we've done is we've advanced our knowledge and understanding of the conditions that we're treating so that we have a much better understanding of what to expect when we evaluate patients and what to expect after we've treated them. I think the complex anatomy and the complex biomechanics and kinematics of the shoulder have really lent us the ability to be innovative, to come up with solutions for things that there just weren't solutions for. The patients that we're treating with reverse shoulder replacements, so that replacement was first FDA approved in 2004 in the United States. So I practiced a number of years before that was available, and we just didn't really have a good treatment for those patients. And that replacement was a game changer for many, many of our patients. So that's an example of that. The arthroscopy, I think, one of the major issues, it's less invasive than the open surgeries we were doing before. That reduces the complications, it reduces the pain that patients have, probably enhances their recovery in terms of how quick they can get up and going after surgery. So we've been fortunate to see a lot of advances, and I think there are more advances coming. We're working on different variations of shoulder replacements. There's going to be a whole new kind of field of biologics. What can we do to help rotator cuff repairs heal better in the future? And I think we're just at the forefront of that as well.
Great, an exciting time indeed.
And Pete, one more thing I'll just add to that is the kind of last step is the patient outcomes. And so there's been advancement in technology on tracking patient outcomes. Before, it was kind of, all right, how'd you do? Okay. But then there was no real science to it necessarily. Now there's a number of ways to do that. And at the Division of Shoulder and Elbow at University of Orthopedics, we utilize one of the systems. And for all the patients that undergo surgery, we track specific outcome measures on them, specific validated questionnaires before surgery and then at time points afterward. So we can see how patients are doing, whether there's factors that are affecting the outcome after surgery. So we're constantly evaluating and trying to improve, because if you're not looking at your outcomes, you're not looking at your results, then you miss opportunities to make beneficial changes.
That's a great point. And you remind me of a conversation I had with Dave Pizzullo, who we were talking about in physical therapy, and he always talks about outcomes. How important is that relationship you have with your physical therapist, communicating about patients and treatment?
So that's critically important. When I joined University of Orthopedics in 1993, we had one physical therapist. And I knew how much physical therapy you needed to take care of shoulder patients. So I started to build the division, and I think Dave was it wasn't too long after that we brought Dave Pizzullo in from the University of Pittsburgh. And he was a native from Rhode Island. And with him and a number of other people, we slowly built a bigger and bigger group of outstanding physical therapists. And I think we pride ourselves on having physical therapists who are bright, motivated, can learn about the conditions, and they really do an outstanding job of taking care of our patients. And I have to thank them again for being so devoted to what they're doing and helping us. That it's just critically important to be able to know that the therapist is going to do what we anticipate, that the therapist will be able to interpret for the patient what works for them, and to recognize, if a patient's having a difficult time, how to modify the rehab for them, how to encourage them, and then how to get them back to the functional status that they're looking for.
Dr. Paxton, anything to add to that as far as communicating?
Yeah, I mean, one of the benefits, again, I go back to this subspecialization, is that we do a fair amount of these procedures. And so then our therapists, in turn, see a lot of patients that have had these procedures done. which can be a big benefit because they know the red flags, they know the warning signs oftentimes before, a big issue may arise, and we'll get a message, we get a little message, hey, I think so-and-so is lagging a little behind. Can we do this? Can we adjust this? Maybe you want to see this person earlier. Just to let you know, this person's doing really well. We may need to advance. And so having the communication and the open dialogue is beneficial, but also their expertise in knowing what to expect and what is normal, what is abnormal, what they should, send the patient back to see us for is really important. And it really helps to provide a better outcome for the patient, I believe.
And Dr. Green, you've, as you mentioned, you saw the practice with one physical therapist, now with a large team. The facilities are top-notch too. What could patients expect during that process?
You mean during the physical therapy process or the whole?
From the equipment setup to really what you all have done to create a good patient experience for that recovery.
Well, it starts with our staff, and I have to thank our staff because the staff they're the people who bring the patients into our office in the first place and help schedule and coordinate things. And then the people who we work with in the operating room who facilitate what we're doing in terms of the surgical treatment, and then the post-operative care, which we supervise, but we're really dependent on the physical therapist. We have a variety of equipment and things we can do. What's most important is to know the concepts. Our therapy generally goes in phases where in the beginning we're protecting the repair, but also starting to regain mobility. The mobility is the key to the shoulder. It's basically, it's a most mobile, least stable major joint. So you really have to have mobility. And then once we get their mobility, then we start working on strengthening gradually. We understand what the healing concepts are, so we can add exercises that are appropriate and safe. But the beginning is the mobility, then the strengthening, and then once patients have gotten a certain level of strength, we return to functional restoration, whether that's for athletics, recreation, work, and we're coordinating that with our therapists. We've developed protocols for different procedures, so they have guidelines, but we anticipate that there'll be some variations depending on the individual patients.
Great. And going back to some of the questions that we've had come in, and we encourage more, we'll try to answer as many as we can. We covered rotator cuff injuries, but a question came in, do all cuff tears need surgery? Dr. Paxton, what's the answer to that question?
So the short answer is no. We know that there's a relationship with rotator cuff tears and age. So as patients get to a certain age, there's a relatively high rate of patient may have a rotator cuff. As they get to 80 years old, there's almost a 50% chance they may have a tear of the rotator cuff. We're not operating on half of the people who are 80 years old. We don't have a great understanding, to be perfectly honest, of why some rotator cuff tears hurt and why some of them don't. So no, they don't all need to have surgery. But again, like we talked about before, we do differentiate between that acute injury, say a younger person or even an older patient who had an acute injury and had a nice healthy tendon and muscle that they just ripped right off the bone. Those are ones that oftentimes, obviously with shared decision-making and evaluation, but that we would recommend earlier surgery for one of those acute injuries to try and get the tendon back to the bone. The more wear and tear degenerative tears, oftentimes we can try some conservative treatments such as therapy rehabilitation program, which there is relatively good evidence to support that patients can respond to that. They will still have a tear. The tear won't heal, but in some patients, that's okay. And so again, discussing risks, benefits, pros and cons of everything, but we treat a large number of rotator cuff tears without surgery, and a lot of patients do well. That doesn't mean they all do well without surgery, but it doesn't mean they all need surgery. And so that's where that tailored approach really comes in to play.
Great. And you both were recognized recently by Expertscape for the publishing of research. You're affiliated with the Warren Alpert Medical School of Brown University. Why, Dr. Green, is that research so important?
I think I've been involved in a lot of different research over the years. Generally, when you're doing research, you have interest in answering a question, whether it's about the outcomes of conditions and treatment, which I've been very interested in, what it is that determines outcomes, and you're asking a question that is of interest to yourself, obviously, but also I like to have research or do research that's going to give an answer that's going to be important to people, that's going to affect how people think about evaluation of patients, treatment of patients, delivery of healthcare. And I think that's the real reason. There's also another aspect that we have with our residents and fellows is we're using research to teach people how to think about orthopedics and shoulder surgery in particular, how to be inquisitive, how to ask questions, seek answers, how to interpret research. Not all research is correct or right. I think those are the driving forces for me to do research.
And Dr. Paxton, I know teaching was an important decision, and you coming to University of Orthopedics in Rhode Island. Why is it important to you?
Well, yeah, first of all, I think Dr. Green's being a little bit humble. He's actually the deputy editor for one of the largest largest orthopedic journals for the shoulder and elbow division and the upper extremity division of that journal. And so he gets to see a lot of the research prior to publication, help to edit it and things like that. And so very up to date on what's coming out and a very inquisitive and scientific mind that he has. That was one of the draws that brought me to University of Orthopedics and Brown University was to work with Dr. Green with all of his expertise. I additionally, I have an inquisitive mind. I like to ask questions, and if there's a question that doesn't have an answer, that's where research comes in, where we try and get an answer. So it helps fulfill that for me. And it also is just another avenue to continue learning. And also, one of the other benefits is it allows collaboration with other like-minded shoulder and elbow surgeons around the country and even the world, which again facilitates dialogue and communication, all in the effort to improve my knowledge base so that I can bring that to take care of patients.
You had a situation, we did a video a few years ago of a strong man in Rhode Island who had fallen and broken his elbow. Talk about how treatment plans are different. There's no one set treatment plan for each patient. You look at the patient and how do you, I'll ask you both this question, what is that treatment plan? How is it tailored and how is it different from patient to patient and situation to situation?
So I'll start. I think we're going to come back to evaluating a patient and being thorough. So when you meet a patient, we find out about them. We ask them questions about their history. We ask them to tell us about themselves so that we understand who they are, what their goals and expectations are. And a lot of medicine has become looking at a test and not looking at a patient. And I think you miss out when you do that. So we're treating patients, and every patient has a life story, a history behind their shoulder problem that we need to understand. And then when we examine them and look at their imaging studies, put that all together as the package to do what Dr. Paxton mentioned earlier, which is shared decision making. And that means understanding the patient. And the professional athlete will have a different expectation than a middle-aged or older patient. They may have a similar perception about what their goals are, although the level of activity or achievement may be different. But ultimately, what we're trying to do is provide a successful outcome to a patient that makes them happy and they're satisfied with. And that those could be different goals for different patients. And we see that, and you have to recognize that. And if as a physician or surgeon you don't recognize those issues, you may end up giving the wrong treatment to a patient that may technically be right, but may not achieve the outcomes or the goals that they're looking for. So we have to be very cognizant of that and sensitive to that.
Dr. Paxton, I'd like to hear your thoughts on that as well.
Yeah, so I echo a lot of what Dr. Green said. I mean, part of what makes shoulder as a challenge, but also enjoyable and fun. And one of the things I liked about it going into it, I don't think I necessarily fully understood that when I was a resident before I got into being an attending surgeon. But really, I could have 3 patients in 3 rooms with the same X-ray or the same MRI, and I could treat all 3 of them differently. And it's really that tailored approach, finding the square peg for the square hole for that patient. And it all starts with a discussion and understanding what their expectation is. If you don't know what their goal is, there's no way you can get them there. And so once you know what their goal is, it may be easier achieved without surgery. It may be something that surgery would be a better option for. It may be something that therapy is an option for, an injection, a specific type of surgery. And so having the knowledge of all the different options, what the pros and cons are of them, and then tailoring to the patient. And I got to say, one of the more enjoyable things that I see that I like is when I have a patient that's come to see me that's maybe had 1 or 2 other opinions somewhere else, and they've been told they had to have surgery, and I'm able to recommend something and have them undergo a treatment path that doesn't involve surgery, and they have a successful outcome, and they're very happy. Even though I'm a surgeon, I love to operate. It's what I like to do. It's my job. That's probably one of the most satisfying things that I can do, is to get someone to that point without involving a surgery. Not meaning I don't, recommend surgery, but sometimes patients are told they have to have surgery for specific things, whereas we really try and approach it more, hear what the options are, let's make a decision together. Because they never really have to have one of these things. It's not a life-threatening problem. So we're trying to restore their livelihoods, their level of activity, and that may or may not be with the surgery.
Yeah, one of the most common things I hear from patients is, I wasn't told that there were different options, or they didn't examine me, or they looked at the X-rays and they said, you need this. And I think patients are becoming more aware, more intelligent about their own health, and are looking for a comprehensive evaluation and discussion of the options. And that's what we want to provide for patients.
And I'm sure you love surgery. That's why you got into it. But what is your ultimate satisfaction when you see a patient?
So, we love surgery because the mechanical part of it, it's kind of fun. But actually what makes my day is when the patients tell me how happy they are, regardless of how I treated them, whether it's surgery or not. One of the most rewarding things about doing what we do is we constantly get positive feedback from other people. And it's a little bit selfish, I guess, it's, to some extent, to feel self-centered like that. But we take care of a lot of people who are very happy, and they tell us that. And there aren't a whole lot of jobs where you can go to work and a lot of people will tell you, you did a great job, you made me so happy, you changed my life. And a lot of that is the attention that you give to patients, that they recognize that.
And Dr. Paxton, same for you. You see folks when they come to your office, they're usually in pretty tough shape, can't sleep. There are people watching out here that will watch this video that maybe ask that question, what can I do? And walk us through that scenario of, what you enjoy going to work for, and what that situation is, and the patient's mind at that point.
So, one of along with everything Dr. Green mentioned, getting positive feedback is great. Who doesn't like to, but it's not necessarily, it's positive feedback on you, but it's positive feedback that you help someone else get better, which is that's why we went into medicine in the first place, is to, try and help people to get better. But additionally, I have patients that come in that say, I didn't think anything could be done. They've had a problem for a long time. I didn't think anything could be done. And we do whatever the treatment may be based on their issue. And within 6 weeks, 12 weeks, or maybe 6 months, if it's a surgery or something, they're better. And they say, I dealt with that for 5 years, 10 years. I didn't think there was anything that could be done. And there is. Or, I just put it off, and I'm so glad that I did that now. And so that's something that I really enjoy as well. But there's nothing better than a happy patient, that you both came with a plan together. You went, you did your part and did a successful surgery. they did their part, which is probably much harder working with the therapist. The therapist did their part, helping them, pushing them along. And then at the end, everyone comes together, the teamwork paid off, and the patient can then go on about their life and not have to worry about their shoulder issue anymore. And that's great.
Great. We have a question that just came in. Dr. Green, you talked about the role of biologics in shoulder surgery. What do you think is on the next frontier for this?
Well, I can tell you what I think is happening now. I'm not sure what the next frontier will be or how that's going to turn out, but there's a lot of work being done looking at healing or enhancing healing of tissues, particularly tendon tissue, and that'll probably translate to ligament tissue, but that relates to the rotator cuff. And there's been a lot of work to look at different growth factors, different delivery systems. How can you get factors into a rotator cuff repair so to help it to heal? Because we know that repairs that heal tend to do better than repairs that don't heal. Without getting into too much detail, one of the issues that relates to that is when do you use it? And does it make a difference in the long term? And we don't really know the long term yet. We don't have a lot of studies that have looked at rotator cuff repairs 15, 20 years later. We were just finishing a study here where we've looked at a number of patients that have more than 15-year follow-up that I treated. And it's been very interesting to see how things have changed in those patients. But we've been focused on healing. I think the other aspect that there'll be a lot of attention to is muscle quality, because when we have tendons that don't heal well in the rotator cuff, they're usually attached to a muscle that's not very healthy. So there's a combination of things. So I think that's where people will be working. There's also going to be innovation in biologics, probably related to reconstructive surgery around the shoulder where there's been bone loss, particularly in certain types of replacement or replacements that have failed after time, and there's bone loss, and we need to do something to reconstruct that. I think it's an exciting field. There's a lot of people working. I don't know that I can predict where we're going to be 10 years from now.
And, you brought up a great question, Dr. Paxton. I think a nice point to talk about that relationship with Brown and that team working in research over there in orthopedics that don't see patients, but your group works closely with in that innovation and the latest and hopefully the greatest things that are out there. Can you talk about that the typical patient really wouldn't know about that's going on in the background?
Well, so one of the, kind of the holy grail, if we would say, of biologics, not just for the shoulder, but for all over the body, would be something that regrows cartilage, that basically a cure for arthritis. I mean, that'd be a pretty big game changer if we had something, you have a horribly arthritic knee, shoulder, whatever it may be, spine, and you inject something into it, and all of a sudden it grows back, and it's like a 20-year-old's knee or shoulder or joint again. And along those lines, there's a large amount of research being done in the academic portion of our group in cartilage research and restoration, and one of the top funded labs actually in the country working on that. And so there's a lot of innovation coming there. We're still, a long ways off from that cure from arthritis. So we're still doing other things like joint replacements and things like that until that day comes, hopefully at some point. But a lot of very exciting research projects being done there with biologics, and then also other exciting things being done in terms of infection prevention and things like that.
Great. Questions are still coming in, so we'll do our best to answer here before we wrap up. We covered some of this, Dr. Green, but a question that just came in maybe for someone joining late. What's the average time of recovery after total joint replacement?
Well, patients ask that all the time, and what I like to do is tell them the stages. So the recovery is in stages. You come in, you have your surgery. Most people go home the next day, and most patients are going to wear a sling for about 5 weeks or so, give or take. And then, but we're going to start rehab the day after surgery. That rehab will be tailored to what their specific condition was. Do they have a good rotator cuff? Was there a soft tissue repair involved? How stable is the joint? And that's going to focus on regaining range of motion. Most shoulder replacement patients are going to be pretty comfortable within a couple of weeks. they'll be up and around. They have a sling so they can walk. The sling is not so restrictive that they can't use their hand, but they'll probably need some help during that time. After 6 weeks, most of the patients are out of a sling. They're able to do their light daily activities. They're pretty comfortable. We're asking them to be careful not to overdo it. After 3 months, most patients have good mobility, very good pain relief, and they're doing their regular daily activities. If you follow patients out for longer, you'll see that they pretty much plateau at about 6 months. And as Dr. Paxton said, though, if you follow them for up to a year, you'll see a little bit of improvement at 1 year compared to 6 months. And I think some of that's going to depend on what a patient's goals are. I have some young, active physical patients who have a procedure for shoulder replacement called Ream and Run, which is designed to allow patients to be very physical. Their recovery tends to be slower because we haven't done a total shoulder replacement. But I think the best thing is to tell the patient what to expect. A lot of patients will say this took longer than I expected because they didn't quite believe us when we told them in the first place. But I think they understanding of that, and I think they go along with it and they do nicely. But I'd say ballpark, it's about 6 months to get to a really good level. But at 3 months, most patients are going to be very functional and comfortable.
Great. Well, we are hitting the 1 hour mark, so we'll try to answer any questions that maybe come in after this. But if anyone has missed who's tuned in, we'll post this online as well on YouTube, and they can get some great information. And as always, reach out to universityorthopedics.com to Dr. Paxton or Dr. Green's office. And you now have telemedicine going on. So if folks are hesitant to come in, that's an option. But right now you're providing a safe environment for patients to come in and move forward. So as we wrap up, Dr. Paxton, any final words for folks that are watching that may be considering seeing a professional because of some pain they're having?
I think we've covered pretty much everything. I mean, that was good for you to mention there. We do have telemedicine appointments available if there are patients that are nervous, if they have underlying conditions, or just don't feel comfortable coming into the office. But we are doing a large number of things in our facilities, screening all employees, screening all physicians daily, screening patients when they come in, a number of other things to make it a safe environment. Yeah, I mean, if you're having a problem that is impacting your ability to live the life that you want to, come get an evaluation. I mean, I've got to say, I have a fair number of patients that come in just to get something, quote unquote, checked out. Just wanted to make sure there was no problem. And sometimes they'll say at the end, "I'm sorry, I didn't mean to come in for that." And oftentimes I say, well, it was kind of nice. This was kind of an easy visit. I'm glad you're doing well. If anything else comes up, let me know, but the x-rays look good. You've got good strength. Maybe we do a little therapy or something like that, and some reassurance. So I don't think there's any problem with that, but sometimes we do find an issue, and then it's beneficial that they came in.
Great. Thank you, Dr. Paxton. Dr. Green, some final words?
Well, Pete, thanks for organizing this. I think it's been a great panel.
Thank you.
We covered a lot of topics. I think one thing that I'd like to emphasize is that this is really a partnership between staff, patients, physicians, therapists, a whole host of people are involved in helping take care of patients. I think it's important to seek out the right type of physician for the problem that you have. We've emphasized the subspecialty component of what we do. We've talked about the more common problems. There are a number of uncommon problems that we see as well, and I think the training that we have and the experience we have allows us or gives us the ability to recognize those uncommon problems, which we tend to see more of because that's all we do when we do the shoulder. So I think I encourage anybody to put in questions or contact us if they have a shoulder problem that they would like to manage.
Dr. Green and Dr. Paxton they're experts in their field throughout the country. So they oftentimes get asked to be consultants for different companies. So we have a disclaimer here that explains that they do work outside of University Orthopedics as consultants. And again, if you have any questions, please feel free to reach out to University Orthopedics. We'll leave it at this, and good night, everyone. Thanks again for joining, and stay safe.
Great. Good night. Thank you.
Good night, everyone. Thanks for joining.